So let's think now about why someone may be short of water. What causes a lack of water in the body? Well, an obvious one is if it's a hot day and someone's sweating a lot, or they're not able to drink water, they don't have access to water, then clearly the amount of water in the body is going to be reduced. They'll become dehydrated. But a very common one, especially in children, is vomiting and diarrhea. Children have much smaller blood volumes, therefore they can afford to lose much less fluid than adults can. But even in adults, vomiting and diarrhea can lead to loss of water. And whenever there's vomiting and diarrhea, as well as loss of water, there's loss of electrolytes, particularly sodium and potassium. Sodium and potassium are the two common electrolytes. To understand that fully, you'd have to watch the second part of this talk. But for now, let's note that vomiting loses water. Vomiting and diarrhea causes loss of water and loss of electrolytes. Another obvious cause is hemorrhage if blood is lost from the body. Patients with burns lose a lot of fluid as well. The skin normally makes the body waterproof. So if a layer of the skin is lost, a lot of fluid is simply lost from the surface of the body by evaporation when we lose a layer of skin in a burn. And as well as that, burns are very insulting wounds, so there's a lot of inflammatory exudate and things comes onto the surface of the wound. So patients can be dehydrated after burns. Burns is a well-recognised cause of shock. We've mentioned excess sweating, hot environments, increased workloads. Fever, we've actually mentioned. Patients can lose water during fever because the body's hot. They sweat, they transpire more water, and they just generally lose more water as a result of the fever. Now, in diabetes mellitus, people can lose a lot of water because there's sugar in the urine. This sugar attracts a lot of water with it because it's osmotic, and you get a large diuretic effect. It's referred to as an osmotic diuresis. So patients with diabetes mellitus can become dehydrated. There's another disorder where there's a lack of antidiuretic hormone. That is called diabetes insipidus, where the urine is very watery due to a lack of antidiuretic hormone. And the last one I can think of at the moment is excess use of diuretics, diuretic drugs in the hospital situation. Or of course alcohol is a diuretic. Alcohol actually inhibits the release of antidiuretic hormone from the posterior lobe of the pituitary gland. Therefore there is reduced uptake of water from the nephron. Therefore more water is left in the nephron. Therefore larger volumes of urine are produced. Therefore the person who's been drinking alcohol becomes dehydrated. And this is one reason why people who drink alcohol get hangovers. They don't feel very well the next day because they're dehydrated and they need to drink lots of water to put this fluid back in. Or better still, not drink too much alcohol and get dehydrated in the first place. So conditions and situations leading to a lack of water in the body. Why might there be a lack of water leading to dehydration? So if someone's got a lack of water in the body, that's called dehydration. How is this recognised? Well, I think we can all relate to this. You get very thirsty and your mouth's dry if you haven't had anything to drink for a while. And you can actually start feeling unwell. Nausea can be a feature as well. And given time, the skin can become fairly inelastic. I mean, if you think about normal skin, if you just take your own arm, for example, when you pinch it like that and just let go, it just bounces back. Skin is elastic. You can't really tell it's been pinched there. But in someone who's dehydrated, the skin becomes inelastic. This is due to a lack of turgor. There's no water in this. There's a reduced amount of water in the skin to give it that bouncy sort of pressure that you get in there, the turgor. So there's reduced turgor leading to inelastic skin. And in children you can see this sometimes on the abdomens. The skin almost looks like an old person's skin because it's lost its natural turgor. There can be muscle cramps in the skeletal muscles, and if it's severe the eyes start to look shrunken because of the lack of fluid behind the eyes. The person can start to feel dizzy, especially when they stand up. That's called postural hypertension. And ultimately, as the amount of fluid in the body drops severely and blood volume starts to drop, then there will be hypotension, systemic hypotension, which is quite a serious, fairly late sign in dehydration. So postural hypertension and ultimately hypotension. Now, you also get peripheral venoconstriction. Peripheral venoconstriction. In the periphery of the body, the veins constrict, they get narrower. This is important because the veins need to maintain venous return to the heart in order for there to be a cardiac output. So it's a natural response of the body that the veins constrict, you get peripheral venoconstriction, to maintain the amount of fluid going back to the heart. So the amount of fluid, the amount of blood in the veins is reduced and the veins are small. Now, because of this peripheral venoconstriction, it makes these patients very, very difficult to cannulate, to get a peripheral venous cannula in. Very difficult to cannulate. So if a patient is likely to become dehydrated, it's very important that we cannulate them to get intravenous access as early as possible. Because if we leave it till the patient's already dehydrated, cannulation becomes very difficult. And very often we need someone with specialised training to go straight into a central vein, such as probably a femoral vein, to start rehydration. As the amount of fluid in the body drops and the amount of fluid in the blood starts to drop, the blood becomes more viscous. This makes the circulation sluggish, and this means that the amount of blood perfusing all of the major organs in the body is reduced. So, for example, in the brain, this can lead to confusion. So patients that are very dehydrated can be very confused. They might not quite know what the time is or where they are, or they're just generally confused because of a poor blood supply to the brain, because the blood is too thick and viscous to perfuse the brain properly. As well as that, the kidneys can be hypoperfused, and that can further reduce volumes of urine. And in fact, dehydration is a possible cause of acute renal failure. Acute renal failure is described as any time when there is less than 30 ml of urine being produced per hour. So if a patient is producing less than 30 ml of urine per hour, we can classify that as an acute renal failure. And that can lead on to progressive renal function, which even can be irreversible. So impaired renal function will lead to an increase in the amount of urea and other waste products in the blood. And the blood will become more concentrated, so the hematocrit will rise, the percentage of blood which is red cells will rise, and there'll be an increased amount of sodium, an increased concentration of sodium in the blood as well. So these are some of the features to look at that may indicate dehydration. So signs and symptoms, the features of systemic dehydration. Dry mouth and thirst, nausea, patient doesn't feel very well, inelastic skin, muscle pains, cramps, sunken eyes and lower blood pressure. Both later signs, both fairly serious signs, those. Peripheral venoconstriction to try and maintain venous return, but making the patients very difficult to cannulate. Increased blood viscosity, leading to sluggish circulation, leading to reduced circulation of many organs in the body, impairment of function in many organs, for example, in the brain, leading to confusion, and ultimately to an acute brain failure, coma. Impaired renal function can lead to increased plasma urea, and there will be a hematoconcentration, a concentration of the blood with increasing amounts of red cells making it sluggish and increasing concentrations of plasma sodium. Well, let's go on now and finish off this part of the talk on water and fluid deficit by thinking about treatments. Now, when fluids are lost from the body, the overwhelming principle is that you need to replace the type of fluid that was lost. Replace the type of fluid that was lost. But it partly depends on the volumes that are lost as well. Let's think about hemorrhage first of all, where blood is lost. Well, if there's a relatively small blood loss, say 400 or 500 mils, the patient might feel unwell, feel dizzy, but if you lie them down and give them a drink, they should recover completely in 10-15 minutes. Even slightly larger blood volumes, the patient might recover just with oral fluids if they've lost slightly larger blood volumes. If the patient is unable to maintain their blood pressure, then they're going to need intravenous rehydration. Now, again, with moderate blood losses, that might just be intravenous infusions of colloids or crystalline fluids. But if greater amounts of blood are lost, then the blood loses its ability to carry oxygen. And at the moment, the only treatment we have that can improve the oxygen carrying capacity of the blood is to put in more red cells. In other words, the patient needs a blood transfusion. So if whole blood is lost, then very often the patient will need a transfusion of whole blood. So again, the principle is putting back in what was lost. With smaller volumes, the patient can recover quite quickly when they lose smaller volumes of blood because there's spare red cells in the spleen. So if you replace the fluids by drinking, there'll be spare red cells in the spleen. But larger volumes do need blood replacement. Now, sometimes the plasma component of the blood is lost. For example, in burns, when the surface of the skin is burnt, then there's a lot of inflammatory exudate, but also a lot of water is simply evaporated from the surface of the body. So in burns, the plasma component of the blood can be deficient. And this can also happen with inflammatory conditions such as severe peritonitis, where a lot of fluid is lost into the peritoneal sac. So these conditions often need treated with intravenous rehydration as well. Now, if it's up to a litre of replacement therapy, then sometimes crystalline fluids can be enough, saline or dextrosaline, something like that. But the rule of thumb often used is that if there's over a litre of fluid lost, then it's necessary to give colloids, colloidal infusions. Now, colloids are infusion fluids with large molecules in them. And these large molecules, the idea is that they stay in the bloodstream, they stay in the intravascular compartment and increase the plasma volume. So human albumin solution, quite expensive but quite effective at doing this. Dextran solutions, large molecules, something like Dextran 70. And there's various polygelatin infusions, Hemocell or Jellifusin, that might be available to you that do the same thing. So I've looked at hemorrhage, we've looked at burns. What I want to focus on, however, is the treatment of dehydration, and we'll do that after we've looked at these notes. Now, dehydration can occur whenever there's insufficient water intake, for example, if someone does not have access to water, or there's excessive water loss, for example, during prolonged hot weather or exertion during hot weather with not enough drinking. But a very common condition that causes potentially life-threatening dehydration all over the world is diarrhea and vomiting, usually caused by some gastrointestinal infection, very often caused by impure water supplies. Now, when someone's got diarrhea, especially children, and remember, diarrhea and vomiting is the most common cause of death in young children in the world. It's a very common, serious condition. When someone's got diarrhea, it's obvious that they're losing water because there's vomiting and there's diarrhea, and it's easy to see that they're losing a lot of water. So obviously, that water needs replaced. But what is less obvious is that they're also losing a lot of electrolytes. Now, the electrolytes we're interested in are sodium and potassium. Now, sodium and potassium are found in the secretions of the gastrointestinal tract. So when there's diarrhea and vomiting, a lot of sodium and potassium are lost. And these electrolytes are absolutely essential to life. So what we need to do when we're replacing the fluid that's been lost by diarrhea and vomiting is also replace the electrolytes. This is absolutely crucial. So please, whenever you're talking about dehydration, always think about fluids, yes, but electrolytes as well. And this is the principle behind the oral rehydration solutions. So diarrhea and vomiting. When we're treating it, we need to replace water and electrolytes, the sodium and the potassium. These must be replaced. This is the principle behind the oral rehydration solutions. Now, when someone's losing fluid, if they've got diarrhea and vomiting, they should carry on drinking normally. In children, it's very important that they carry on receiving breast milk. And whatever drinks they fancy, really, orange juice or coconut water should be given as normal. So carry on giving the child drinks. But as well as that, in more severe cases, specialised oral rehydration solutions may need to be given. So water is lost in diarrhea, sodium and potassium are lost in diarrhea. We've said that the overwhelming principle in fluid replacement is to replace that which was lost, so we must replace both the water and the sodium and potassium. This means we need to give oral rehydration solutions that contain salt and potassium as well. But this is very useful actually, because sodium and glucose are actively taken up by the wall of the duodenum. That means that the duodenal wall will actually take in actively the sodium and the glucose that's in the lumen of the duodenum very quickly and actively. So that means you've got glucose and sodium in the cells of the wall of the duodenum, and that means that the water is sucked in from the duodenum osmotically very quickly. So yes, it's necessary to give sodium and potassium to replace the sodium and potassium that was lost. But if we can, but as well as that, the sodium actually means that the water is absorbed much more quickly if it's combined with glucose. Because if a child's vomiting or an adult's vomiting, then they're going to lose the fluid before they've had time to absorb very much of its pure water. But if the water is mixed with salt and with glucose, it will be absorbed much more quickly. So it rapidly increases the intravascular volume as well as replacing essential lost salts. Now, as well as that, in diarrhea, especially in children, hypoglycemia is a serious risk. Children can become very hypoglycemic, and this is life-threatening. So when a child's got diarrhea, they're under threat from water loss, from electrolyte loss, from sodium and potassium loss, but also from sugar loss. Well, not sugar loss, they just don't have sugar, from hypoglycemia. So again, if we put sugar in the oral rehydration solutions, it's going to help put the blood sugar levels back up, but it's also going to increase the rate of absorption. So oral rehydration solutions should contain clean water, which has preferably been boiled if you don't have a clean water supply, some salt, preferably some potassium, and certainly some glucose. This will mean that things the body are deficient the things the body is deficient of will rapidly be replaced, and it also means that the rate of absorption will be much greater. And it's important to teach parents about these principles so that they can treat diarrhea in their children very quickly. For example, this little spoon here, this cup is for glucose or sugar, this one is for salt. You can just give these out to parents if you've got access to them. They're fairly readily available. This one's from an organisation called Talc, Teaching Aids at Low Cost. I'll just read what it says. To make the dose, add to each cup of water 1 level scoop of sugar in A, that's that one, 1 level scoop of salt in B. Take the dose after every diarrhea. A child must take 1 dose, an adult must take 2 doses. And on the back it says, taste, do not use, if more salty than tears. So it's very simple. If a child has diarrhea at home, mothers can be taught to give them some drinks containing sugar and containing a little bit of salt, and preferably a little bit of potassium as well. That can be available from things like fruit juices, or lemon juice can add to the amount of potassium. So they're the deficiencies we've discussed. Now, if a child's already very ill, it might be necessary to put down a nasogastric tube and drip in some oral rehydration salts. If a patient is already unconscious, of course, we certainly can't give them drinks because it will just go down in the trachea. Sometimes oral rehydration solutions can be given rectally as well. The colon can absorb several litres of fluid a day, and that can be done by people with fairly low skilled levels. They can just put the tube into the rectum and infuse some fluid into it. But if the patient's more ill, they may well need intravenous rehydration. So water is lost in diarrhea and vomiting. Okay. Potassium and sodium are lost from the gastrointestinal secretions, so the body will become short of them. However, sodium and glucose will be actively taken up by the wall of the duodenum using a process called active transport. And the water will follow the sodium. Sorry, I said sodium and potassium. I meant sodium and glucose is actively taken up by the duodenum. And because these are both osmotic molecules, the water will follow them in to the cells and therefore into the capillaries, therefore restoring intravascular volume. Hypoglycemia is a problem with diarrhea and vomiting, especially in children. So when children have got diarrhea and vomiting, if you can give them something to eat as well, preferably a high energy food, that's a very good idea. Never ever believe the myth that you should starve people who have diarrhea and vomiting. They should eat what they can to keep their blood sugar levels up, especially in children. Now we can use perrectal administrations for people with low skill levels. Just put in a PR tube and start the drip. And that may give enough fluids to make the patient more conscious, who can then be given oral rehydration salts. Alternatively, we can pass the nasogastric tube and also put oral rehydration solutions directly into the stomach. In severe cases, very often, the treatment of choice would be intravenous infusions if available. Now, rehydration may need to be fairly rapid if there's signs of organ failure. We're really talking about an emergency situation. So, organ failure might be noted by, say, confusion indicating brain failure, or oliguria indicating renal failure. Then it might be necessary to consider giving colloids to increase organ perfusion. And this might need to be done fairly rapidly, maybe up to a litre of fluid given over an hour. But there is a problem here. When patients have been severely hypovolemic, then the body responds with peripheral venoconstriction. The peripheral veins narrow. Now this is important to maintain venous return while the patient is dehydrated. But the problem is, if there's over-rapid correction of hypovolemia, of low blood volumes, this doesn't give time for the venoconstriction to reverse. And this means that circulatory overload can occur even although the patient is still dehydrated. So it's not just a question of putting in lots of fluids, it's a question of carefully monitoring the condition of your patient. And if there seems to be problems with circulatory overload, which we've already discussed, for example, if the patient starts to feel short of breath, then the rehydration rate needs to be slowed down, maybe to something like a litre in 4 to 6 hours. And of course, if you can possibly prevent dehydration occurring, for example, during surgery or after trauma, that is much better. Now, what I want to emphasise next is that smaller people have lower blood volumes. I know it's fairly obvious, but at 6 months of age, a child only has half a litre of blood. So you can see in young children, if they've got diarrhea and vomiting, because they've got relatively low volumes of body fluids, only half a litre of blood, then they can become dehydrated really quite quickly because they haven't got as much fluid to lose as an adult. So the younger the patient, the more life-threatening diarrhea and vomiting can be. So that more or less concludes this section of the video on fluid loss. And just to emphasise one more time, because this is so important, in diarrhea and vomiting, especially in children, loss of fluid and electrolytes can lead to the death of that individual child or person. Water, sodium and potassium are lost, and also the child is at risk of low blood sugar, hypoglycemia. Replace clean water with salt and a potassium supplement and glucose, and you can save the life of that child. Teach mothers to treat early at home before dehydration becomes established. The use of oral rehydration salts is probably the greatest single medical advance of the 20th century in the amount of lives it saved all over the world. It's very important that people who lose fluid and electrolytes, especially young children, have them replaced as quickly as possible. Very last thing on this section, a few recipes for you. Now, very often pre-prepared sachets of oral rehydration salts are available to make up oral rehydration solutions. World Health Organization and UNICEF make up these and distribute them widely. Normally, one packet of salts dissolved in 1 litre of clean water. As we've stressed, it's vital that the water is clean because contaminated water may well have been the cause of the diarrhea in the first place. An alternative recipe, just a very basic recipe, is 1 pinch of salt. Now this is a 2-finger pinch, the amount of salt you can get between 1 finger and your thumb. So a pinch of salt, heaped teaspoonful of sugar, 1 cup of water, and some lemon juice or any sort of juice added in to give the potassium. So that gives the saline, the salt, that gives the sugar, that gives the water, and that can help with the potassium. A more advanced solution that can be made up by pharmacists, something like this: sodium chloride 3.5 grams, sodium bicarbonate 2.25 grams, potassium chloride 1.5 grams, glucose 20 grams, all in 1 litre of pure water.